Good afternoon, everyone. Welcome to the School of Public Health Grand Rounds here this afternoon. This afternoon's Public Health Grand Rounds is co-sponsored by the WVU School of Public Health, the WVU Injury Control Research Center, the ICRC, the West Virginia Prevention Research Center, and the University of North Carolina Southeast Public Health Training Center. Thank you to all the co-sponsors for supporting the Public Health Grand Rounds as a continuing education program. I'd like to thank our speaker for this afternoon, Dr. Ekta Choudhary, who is a former student of ours, both as an MPH student as well as a PhD student. Dr. Ekta Choudhary is an epidemiologist at the Environmental Public Health Tracking Branch, National Center for Environmental Health, Centers for Disease Control and Prevention. She received her master's and doctorate degrees in public health sciences from WVU. Dr. Choudhary has also worked as an injury risk assessment specialist with the National Park Service, where responsibilities included developing a risk assessment tool and set up surveillance system to track injuries. She joined CDC in 2009 as an EIS officer, Epidemic Intelligence Service Officer, and as an EIS officer, her work focused on emergency preparedness and response to outbreaks of environmental, etiology, and natural disasters. Currently at Environmental Public Health Tracking Branch, she provides expertise in developing content area for the National Environmental Public Health Training Network, which is a nationwide environmental health surveillance system. This brings us to this afternoon's presentation. So now, without more undue time, I'd like to call on Dr. Choudhary for this lecture today. Thank you, Dr. Choudhary.
Thank you. Well, I first want to start by saying thank you for inviting me. It's always good to be back in Morgantown. Get some old faces, some new faces, and it's just looks like it's an exciting time here right now. So I'm happy to be back and happy to see all of you. I'm going to start with the presentation is broken down into two major studies in a way. It's two different disaster outbreak responses. One is a natural disaster, and one is a man-made disaster. And I'm going to talk about how disaster epidemiology tools were used for different scenarios, different type of population, and different type of objectives. So I will try to show you two different methodologies of disaster epidemiology. So majority of you are already familiar with it, but I'll start with a very brief definition of disaster epidemiology. Is defined as the use of epidemiology to assess the short and long-term adverse health effects of disaster and to predict consequences of future long-term disasters. It brings together different areas of public health together. It's not a standalone epidemiology section by itself. Depending on the nature of the disaster, depending upon the needs, it brings together communicable diseases, environmental health and occupational health, chronic diseases, injury, mental health, and behavioral health. The main focus of the disaster epidemiology when it is used for the response part of it is actually to provide situational awareness. And what do I mean by situational awareness? It is to provide information that help us understand what are the needs of the population that got affected by a disaster, plan the response to make sure that we address those needs, and gather the appropriate resources that are needed when we go out there and serve the population. So the main objective of disaster epidemiology is to prevent or reduce the number of deaths or illnesses or injuries caused by a disaster, to provide timely and accurate health information for the decision makers so they can allocate resources and mobilize resources accordingly, and improve the prevention and mitigation strategies for future disasters so the information that's collected during one disaster setting can then be used for the next time a similar situation occurs. So as I said in the beginning, I will talk about two examples of community needs assessment and then assessment of chemical exposure, different type of disaster, different type of needs, different population, and what we did. And these were the actual incidents that happened, and I actually responded to both of these situations. So I will first start with the public health needs assessment of the Tula Island in American Samoa after 2009 tsunami and earthquake. To start with a brief geographical location of where American Samoa exactly is. It's a small group of islands. It's around 5 islands which are located in the South Pacific Ocean, southeast of the nation of Samoa, and east of Australia. It actually became an unorganized U.S. territory in 1900, and it is till date is the only U.S. territory that is located south of the equator. And the Tutuila Island is actually, you can see on the left-hand side, the lower panel, and the capital city of American Samoa is Pago Pago, which is almost located in the center of the island. So what exactly happened? On September 29, 2009, an 8.3 magnitude earthquake was recorded in the Pacific Ocean. The epicenter was located 120 miles southwest of American Samoa. Approximately 50 minutes after the earthquake, 4 tsunami waves around 50 to 20 feet high struck the island of American Samoa. The tsunami waves caused extensive damage to the capital city of Pago Pago and the other coastal areas. The disaster-affected area included both commercial as well as residential areas. The impact of the waves caused immediate damage to all public utilities. It led into the widespread loss of water, power, and sanitation facilities. And there were 34 people who actually lost their life as a result of the tsunami and the earthquake. So in order to assess the public health needs assessments after the tsunami, we conducted a community assessment for public health emergency response, which is most commonly known as a CASPER. CASPER is an epidemiological technique. It's designed for rapidly assessing the household level needs in disaster affected areas. It can be implemented quickly, efficiently, and following a disaster, providing accurate and reliable household-based information for decision makers. And it can also be used during the recovery phase to monitor how needs have changed over time and how different interventions or the relief efforts are working. One thing I want to highlight here, especially with CASPER, is that when you're looking at the findings of the CASPER, when you're implementing the findings of the actual methodology, it's giving you information at the household level. It's not an individual level data that is being collected. It's one person in the household that actually is responsible for informing about the household. So it is one household unit that we have. So our numbers, when we're looking at it, is not per person, it's per household. And I will go into a brief detail of methodology in a couple of slides. So here's the timeline, what exactly we did and what exactly were the purposes of doing it at CASPER. So the earthquake and the tsunami response in American Samoa was conducted in 2 phases. On the top of the timeline is the initial phase, and then below the timeline is actually, the boxes highlight is the follow-up stage. So the first phase, the initial CASPER, was conducted 5 days after the tsunami to identify the immediate public health needs. The findings from the initial CASPER were reported to the American Samoa Department of Health on October 4th. And since the disaster was so large, it affected the whole island, the American Samoa Department of Health still had an ongoing concerns about the needs of the public and how the population is actually receiving different relief efforts. So 3 weeks after the tsunami, the follow-up CASPER was conducted over a 3-day period from October 22nd to the October 24th. And the findings were reported to the American Samoa Department of Health on October 26th. So one of the unique thing about implementing a CASPER is the timeline. You can implement it quickly. It can be, the results can be disseminated, or preliminary results can be disseminated within 24 to 48 hours. It depends obviously on the type of the disaster. It depends on what you're asking, what type of information you want to collect. But our typical timeline is to actually go there, train the individuals, and implement, and then get out within 48 to 72 hours. So the objective of initial CASPER, which was conducted 5 days after the tsunami, were to describe the basic needs such as food, water, shelter, sanitation, and health of the affected communities, and to identify the special needs, including vulnerable populations such as pregnant women and elderly population, and to determine the risk factors of the further morbidity and mortalities, especially the cases or the individuals that were missed at the beginning of this, right or immediately after the tsunami. But the objectives are very different when we did the follow-up CASPER 3 weeks after the tsunami. It was mainly to assess the effectiveness of the public health response since the initial CASPER and identify ongoing community public health issues and needs. And in my presentation, I'm going to focus mainly on the follow-up CASPER, but it will be using a lot of data from initial CASPER, and I'll explain that in a moment. So what exactly is a CASPER? How this methodology is implemented? It's a multi-stage probability sampling. It's been used by the World Health Organization initially to actually do a lot of immunization-based work in Africa. And then this methodology was then improved over the years, brought it back, and we were using it for disaster response for over a decade now. So what do I mean by multi-stage probability sampling? What it does is, in the first stage, we collect 30 clusters, or in a more simplistic public health language, I will say census blocks. So we collect 30 clusters or census blocks randomly chosen with probability proportional to size for a list of census block in the affected area. In the second stage, we will have 7 households within each cluster that were actually interviewed, and those are randomly selected as well. The data collection instrument, or a survey, was designed on site with the input from American Samoa Department of Health in this instance, and also American Samoa EPA, United States Department of Health and Human Services, and it was captured, as I said, to the data on a household level. Data were then weighted and obtained a population estimates of household needs, and all analyses were done using EpiInfo and SAS. So this map right here is of the Titula Island. Pago Pago is highlighted as a star in the center of this island. And this same sampling frame, i.e. the affected area, was used for both initial as well as for the follow-up CASPR. The assessment area was determined by American Samoa Department of Health. It was a local officials knew better about their area. They knew exactly what's going on. They knew which area were heavy residential. They knew which area were commercial. So they wanted to choose the areas that was chosen by them. What we actually came there is we used the sampling frame, and then we obtained clusters from the same sampling frame. So the blue lines that you see on this map are actually the coastal areas that are heavily impacted by the tsunami. And the census block highlighted here in yellow are the one that were chosen clusters for both initial and follow-up CASPR. So from this sampling frame, 30 census blocks were chosen, and these are the clusters or the sampling of blocks from the initial CASPR. These are highlighted here in the green. Depending on the population size, as I mentioned, is the probability of selecting any type of census block is proportional to the size of the population within that cluster. So some of the clusters were chosen twice because of the larger population that stayed in the area. Now, this second map here shows, from using the same sampling frame, are the cluster that we chose for the follow-up CASPR. And so you will see there was a lot of overlap. I'll just go back from one side. There was a lot of overlap between the clusters that were chosen from the initial CASPR as well as for the follow-up CASPR, because we had the exact same sampling frame. So the assessment tool, or the survey that was designed for both CASPRs, included a range of questions from physical location of the household to the greatest need. And in addition, in the follow-up CASPR, we added additional questions that were focused on the disease vectors and the mental health concerns, which are highlighted here in the yellow. And I will go into the findings, and it will become clear why these were added at the later stage. So here are the population estimates of the initial CASPR, which I will then go into the follow-up CASPR to just show the comparison in terms of what our findings for the basic demographics were. We conducted 212 surveys. In the initial CASPR, the response rate was 78%. 32% of the households reported having children under the age of 2. 30% reported adults who were 65 years or older, and 9.4% of the households included pregnant women. For the same sampling frame, when we conducted the follow-up CASPR, we had a response rate of 88%. 37% of the households reported children under the 2 years of age, and 35% of the households reported adults who were 65 years or older, and 10% of the households included pregnant women. So in order to assess the effectiveness of the public health response after 3 weeks of the tsunami, household estimates from initial and the follow-up CASPR were used regarding the basic needs, greatest need, and access to medical care. In order to assess the change in these needs between the initial and the follow-up CASPR, percent change was calculated using initial CASPR as baseline. So this table here shows the comparison of household-level basic needs from initial and follow-up CASPR. The percent response and estimated number of affected households in the assessment are shown here. The finding from the initial and the follow-up CASPR were compared by calculating percent change, as I just briefly mentioned, and it's shown in the last column. And an increase between the initial CASPR and the follow-up CASPR percentage response are shown by a positive sign, whereas there was a decrease, it was shown by a negative sign. And what we saw here is that for all basic needs, such as electricity, bottled water, clothing, there was a decrease from initial CASPER, which was right after the tsunami, than the 3 weeks after the tsunami. The self-reported greatest needs, when you just ask what you actually need and what is your greatest need, and they have to choose just one, what we found is that the most frequently indicated greatest need in the initial CASPER was included electricity, which was reported by 34% of the households, water reported by 27% of the households, and financial help for cleanup was reported by 25% of the households. When we went back after 3 weeks and we asked them, okay, what is your greatest need at this point? And what we saw is that food was reported by 26% of the household. That was their greatest need 3 weeks after the tsunami. And financial help with cleanup was the second, which was around 14%. And water was reported by 13.5% of the household. So as shown in the last column, the need for food increased by 20% since 5 days after the tsunami. So this table here compares the medical care needs between the initial CASPER and the follow-up CASPER. And the need for immediate medical care increased by 68% since initial CASPER. And since the tsunami, the number of households reporting needing medical care increased by 30%. And the number of households reporting being unable to obtain medical care or supplies increased by around 8%. So now I will focus on the findings of the follow-up CASPER's second objective, which was to identify ongoing community public health issues and needs. And as mentioned earlier, the follow-up CASPER included additional questions to assess problems related to the disease vectors and mental health concerns that were not included in the initial CASPER. So there won't be a comparison to the initial baseline. So we assessed problems with disease vectors and household methods for mosquito protection. Since the tsunami, 77% of the households reported increase in daytime mosquito bites, 68% reported increase in nighttime mosquito bites, and 50% reported increase in mosquito breeding sites. Why was this so important for the health department to capture this information during the recovery phase? Recovery phase is also known as the cleanup phase as well. There's a lot of debris still around. People are still getting back to their houses. And another problem that Samoa had is that both dengue as well as malaria are a reoccurring problem in American Samoa. So the local health department wanted to make sure that the people are following the recommendations that they actually enforce throughout the years to protect themselves against the mosquitoes. And also if they have seen an unusually high cases that comes to the hospital, they want to know if people are aware of that. And so that's why that was a focus to include vector-borne questions related to vector-borne after the 3 weeks after the tsunami. So because they were concerned, and we also asked them, what are the different methods that you are protecting yourself against mosquitoes? And what we saw that only 6% of the households reported using protective clothing and 18% used mosquito repellents, both of which are the most recommended methods of protection from the Department of Health. So in the follow-up CASPER, we asked 2 separate questions regarding household members' mental health concerns before and after the tsunami. This became more, we have this concern mainly from the pediatric physicians who were in on the island, because they were receiving a lot of mental health concerns or problems among children. So we wanted to know how was it before the tsunami, or did tsunami have something to do with it, and if we have seen any change. So as shown in the last column, there are large increases of all mental health concerns that we asked. So we asked them 2 different questions. We asked them, did you experience agitated behavior, trouble with sleeping, loss of appetite before the tsunami, and then how family members are experiencing these different mental health concerns after the tsunami. And we saw a huge number of increase in just by asking the household members. So it was corroborating the data that we are getting from the local hospitals in terms of mental health needs. So now that we knew what we have, so I'm just going to give a brief conclusion. So based on the data that we have from the follow-up CASPER, we identified ongoing community needs for food, water, and medical care 3 weeks after the tsunami. In addition, households in the affected area reported increased problem with disease vectors such as mosquitoes and flies, as well as an increase in mental health concerns. And in conclusion, the findings of the follow-up CASPER helped the Department of Health at American Samoa to assess the public health response efforts and identify additional needs. So the CASPER provides a rapid assessment of household needs in the disaster-affected area. However, there are several limitations when you're looking at the data. The estimate may provide, first of all, an underestimation of the disaster-impacted area because we can only go to the area that is accessible. If there was a large impact and you couldn't really physically cross or reach the area, we were not able to survey in those areas. So residents who are staying elsewhere when the survey was conducted may have been missed. Field teams were also trained a day before. As I said, it's a very short period of time. You go there, you train the people the same day, they go out and they collect the information. So everybody's interpersonal skills, interview skills, how they collect the data, how they record the data, you basically have a very short period of time to basically train them for that. And that can lead to different variations when you're collecting the data, using especially for the surveys. But we have used a very standardized pre-tested questions that have been used in so many different disasters for more than a decade that we are more confident in the questions itself and the language and the way they are asked, that we have strong belief on the results that we get, but then there can be still variation added. And also, findings are subjected to recall bias. We went there 3 weeks after the tsunami, and also we asked about the question that how were the mental health concerns before the tsunami. So there's a lot of recall bias that may have been infused to the results. So now that we knew what we have, we knew what we can or cannot do with this data, what exactly were our recommendations? So based on our finding, we made the recommendation to develop strategies to address immediate community needs, especially food and safe housing, and provide accessible medical care and medications, particularly for vulnerable population, and strengthen the community education and vector control programs. They still need to reinforce and educate the public about don't ignore the mosquito bites because they really didn't want another outbreak of a dengue or a malaria in the area right in the middle of one crisis. So in addition, we recommended that American Samoa Department of Health and the partners immediately implement a feasible short-term as well as long-term strategies to address mental health. So on behalf of American Samoa Department of Health, we presented these findings of the follow-up CASPER to the governor of American Samoa. Based on these findings, American Samoa Department of Health then received funding to address the immediate public health needs. And in collaboration with the United States Department of Health and Human Services, mental health providers actually developed short-term mental health programs specifically targeted towards the community and the pediatric population. And we immediately disseminated health communications messages to increase the awareness regarding vector-borne diseases and how to control them and how to have safe water use using via radio and television. And another interesting thing that happened is that they actually put up these signs. Oh, by the way, all the pictures that you saw during this presentation were taken by me. And we were all over the island. And one of the things that they did immediately, literally 5 days after the tsunami, is actually to put up these signs which actually says tsunami hazard zone. Problem was, it was facing the sea, not inland where people can actually see it. Another problem, I think, that dude actually looks like it's promoting surfing, then actually telling you to stay from that. So, but that was their first intervention, actually, to put up the sign all over the time. And other, which we learned when we landed in American Samoa culturally, is that they actually don't go to the beach. They don't like going to the beach. They actually consider that land as sacred, and they just don't go to the beach. So if you're visiting there and you happen to be on the beach, there probably will somebody going to come up to you like, why are you here? So it was interesting that they have the messaging all over the area. Okay, let's switch gears. That was a natural disaster response. Now I'm going to talk about a man-made disaster response. And it was a chlorine gas exposure at a metal recycling facility in California. Different population, different needs, different methodology. But before I go there, I actually wanted to show you something. I want you to focus in the right here where you see the big excavators. There's a big explosion that happened on, it's a metal recycling facility. The excavator was cutting open, which thought was a scrap metal. Something came out of it. And obviously when you have something that big, and it was pretty loud. We didn't get the audio because it was a surveillance video on the facility. Everybody thought it's a good idea to just go check it out, what's going on. So they just, so they are just walking towards it and saying, oh, what's going on? And then they started running like, oh, maybe we shouldn't be walking towards it. Maybe we should be walking away from it. And then they obviously, everybody started running out. There were a lot of people. There were like 30 or 40 people that work on this facility. It was a large facility. And you're going to see that if I don't want to stay that long because I want to move on to the presentation, when they left, some of them actually came back. They forgot that there is actually a guy sitting inside the excavator, and they probably should take him out. So they came back, and now they're running towards it and trying to get him out of the excavator. Okay. So what this is, I'm going to use a very boring method of now telling you what happened, what you just saw in a video. So on June 8, 2010, explosive release of greenish yellow gas occurred when a worker at a metal recycling facility in California used an excavator to cut open a 1-ton low-pressure tank. The tank was old, unlabeled, and was presumed to be empty when it was sold as scrap metal to the metal recycling facility. The local hazmat team later identified the gas release as chlorine, and the exact amount of the chlorine inside the tank was unknown, but when they actually went there 3 hours after the incident occurred, there were 328 parts per million of chlorine at the release site. So chlorine, to give you a brief background, is one of the most common toxic inhalants. It is among the most widely used and commonly manufactured chemicals in the United States. Chlorine is a respiratory irritant that can cause symptoms ranging from mild upper respiratory tract irritation to severe inflammation of bronchoalveolar tissue. The effect of chlorine on humans depends upon how much chlorine is present, how one is exposed to it, and what is the length of the exposure is. For example, the lung injury or the pulmonary edema can be caused by exposure to 40 to 60 parts per million. However, if a person is exposed to 430 parts per million for more than 30 minutes, it can result in death. So we had 328 parts per million 3 hours after the incident. We don't know exactly how much was already released when we went there. So on June 14th, California Department of Public Health contacted Agency for Toxic Substance and Disease Registry, or ATSDR, and requested assistance with assessment of chemical exposure, or also known as the ACE program. ACE is a component of National Toxic Substance Incidence Program, which is managed by ATSDR at the national level. One of their congressional mandate is that if there is an incident where there is a chemical release, they are requested by the state to go and help them with the response efforts or whatever they need. So that's the National Toxic Substance Incidence Program's main goal. It is designed to provide a rapid assessment after a large-scale chemical release, and it uses a questionnaire as well, which can be tailored to the toxic substances released. So in this case, we had chlorine, and the question, they have a large questionnaire bank for the most common release or the most common spills that happen. So they have different questionnaires, and you can pick from those and use those for the response that you're going on. So the objective of this particular investigation was to describe the characteristics of the person exposed during gas release, to assess the health effects associated with exposure, and to develop a recommendation for preventing a similar incident from occurring in the future. In order to achieve our objectives, we conducted 3 informant interviews with respondents from local fire department, hazmat team, and the owner of the facility. We identified exposed individuals by asking the employer, reviewing emergency medical services of the EMS records, and by asking those we interviewed for the names of the people who were with them at the time of the incident. We administered a survey in English as well as in Spanish to exposed individuals to characterize the exposure and the acute health effects. We extracted medical chart data for those who received medical care after the exposure. We performed chi-square analysis and Fisher's exact tests to determine if there were risk factors associated with more severe illness, using need for hospitalization as the outcome of measure. So I will now present the findings of the key informant interviews. So I'm going to use this graphic. You already saw a piece of it, of what happened in the video. Now I'm actually going to walk you through the whole picture to just kind of see what exactly happened. And so this figure here shows the site of the chlorine release right in the center. A couple of things here to look at is that there are different shed areas or the covered areas within the facilities. Those are labeled here. The office is right at towards the main gate. There's a big shed which was just covered, and people actually received metal there. And there's another shed in the back where they had another person working. At the back of this facility is a railroad running. In front of it, there's the main road with an intersection, and there are 2 businesses right in front of it. So that's the scenario. Now I'm showing you the actual position of all the people who were working on the facility or were the customers or the bystanders and the people who are also on the other businesses across the street. So this is their evacuation area or the evacuation route. They have practiced this. They have complete OSHA compliance. The facility actually was a very famous facility in the area. They worked with the local law enforcement for different incidents. They actually used to have a lot of problem of people stealing copper wire and selling it them. So they actually used to set traps for people and then work with the law enforcement. So that's why they had surveillance camera all over the facility. And they have a very well practiced evacuation route. They will do the drill almost every 3 months so that in case something happens, they know what to do. And they did know exactly what to do. However, when the explosion occurred, they first thought, okay, let's go check it out, what's happened. Then like, oh, it's an emergency, we're supposed to leave, let's just run. They did run out of the facility. They used their traditional evacuation route, which was very well practiced. Main problem, they ran inside the cloud and got out. So they were not only, at this time, were running through the cloud, but their evacuation area where they were supposed to wait for the first responder to get there was actually they were standing right there and inhaling all this chlorine that was coming all their way because they were following the guidelines that were given to them. So the EMS and fire department arrived at the scene. They set up a decontamination area 200 yards away from the facility at the road intersection. And the county fire department then contacted the nearest hazmat team, which arrived 2 hours after the incident and identified the gas as chlorine. So all this time, they didn't know what it was. All they saw is that there's a big explosion. There was a gas. They ran with it. They evacuated the area. And they just waited for 2 hours for somebody to come and tell them what it is. OK, so then we had to identify every single person who got exposed. Because we were able to identify all of them, that's why I was able to get the exact location. I asked every single one of them where they were, and we were able to map them on the facility. So the one that you saw was not just randomly placed figures here and there, that's where exactly they were at the time of the incident. So there were 29 individuals that were present near the metal recycling facility at the time of release. 16 were the actual employees of the facility. 13 were either customers, bystanders, or those who are present at the nearby businesses. We were able to interview 27 of the 29. 23 exposed individuals received medical care at 7 local hospitals. Anybody who's a physician here or ever worked with collecting medical chart abstraction data from one hospital can multiply that by 7 and try to get that from both ED as well as inpatient care. And also, in addition to that, we got EMS records because majority of them were transported to the 7 different hospitals via EMS. And the 17 individuals were treated as outpatient, as 6 were hospitalized for inpatient care. So now I will show you the ACE survey that we actually conducted to all these individuals, to 27 of them. This table here shows the basic demographics of the exposed individuals. 78% of them were male, and they were of Hispanic origin, majority of them. The mean age was 40 years. The majority of the exposed individuals were adults, but we did have one 17-year-old and a 2-year-old who were accompanying their parents. They were actually customers of the medical recycling facility, and they were also happened to be at the time of the incident and present at the location. So we asked interviewees where they were at the time of the release. 56% of them reported that they were outside. Most of the workers at the recycling facility worked primarily outside. We calculated exposure time by subtracting the incident time from the decontamination time, because they had to wait till somebody came up and started the decontamination process. And these findings show that approximately 48% of the individuals were exposed to at least 30 minutes or more before they were decontaminated. So once the law enforcement arrived at the site, they asked the evacuation of the area as they were not sure about the type of chemical that had been released, and 92% of the individuals said that they did actually evacuate the areas after the authorities got there. And when asked if they were decontaminated, 81% of them said yes. Some of the exposed individuals were decontaminated more than once and using more than one method. Once they were decontaminated by the local fire department when they came on the scene, and then once they were transported to the hospital, they got decontaminated again. And the majority of the exposed individuals were decontaminated using water. We asked if exposed individual experienced any symptoms or illness within 24 hours of exposure, and 84% said yes. And 85% of the exposed individual who also reported that they received medical care at the local hospitals. Those who reported illness within 24 hours of exposure were also asked about the type of symptoms they were experiencing. And this table shows the list of the most common ones that were reported and the highest number that we had. And they were all over the board. The majority of them were coughing, headache, and burning of the upper respiratory tract. Few of the individuals reported pre-existing medical conditions such as high blood pressure, diabetes, and allergies. And these were then reported mainly by the individual who were older and were working at the metal recycling facility. Then we reviewed the the information that we extracted from the medical charts from the 23 individuals who received medical care at the local hospital. So as a result of the chlorine exposure, 6 individuals were hospitalized. Of these, 5 were the actual employees of the metal recycling facility. The range of the hospital stay was 1 to 11 days, and the primary diagnosis of hospitalized patients were hypoxia, hypoxemia, chemical exposure, and acute lung injury. And both hypoxia and hypoxemia here to give you references to referring the low oxygen levels. And the medication prescribed during hospital stay included bronchodilators such as beta-2 agonists and nebulized anticholinergics. 17 individuals were seen at the emergency departments in 7 different hospitals and were released the same day. Their primary diagnoses are shown in this table, and similar to the previous incidents that ATSG have responded to, the primary diagnoses were not consistent. Many were categorized as chemical exposure, chlorine exposure, or chemical inhalation. So we compared the exposure characteristics of hospitalized and non-hospitalized individuals just to see if we saw any differences. So the exposure characteristics such as proximity to the location of the tank when the exposure occurred, duration of exposure to chlorine, and location of the individual at time of release and pre-existing medical condition of hospitalized individual with non-hospital individuals were compared. We actually didn't see any statistically significant difference in the proportions at all. So in conclusion, additional exposure to chlorine occurred during evacuation when the employees followed the predetermined evacuation route and ran with the gas cloud. Delay in the decontamination may have resulted in prolonged exposure during the wait of the first responders. And in spite of the additional exposure and delayed decontamination, the majority of the exposed individuals experienced mild symptoms. And no significant association were found between exposure characteristics and the need for hospitalization. And obviously, there are limitations to this investigation when we performed. We didn't know the exact amount of chlorine that was in the tank, so we couldn't really assess how much doses or the exposure each individual had. Also, the exposed individuals were interviewed a week after the incident, so there is a potential for recall bias as well. And due to the small numbers of the individual, the significant differences between the hospitalized and non-hospitalized individuals probably were not observed. So based on our finding, what did we do? We actually made 2 sets of recommendations. One to the California Department of Public Health, and we told them to disseminate information on chlorine exposure and its health effects to exposed individuals and healthcare providers. Educate business owners on how they should recognize and safely handle the potentially hazardous material that they receive. And the continuous to monitor the long-term as well as the short-term effects of chlorine among those who were exposed in this incident. We made a second set of our recommendation to the recycling facility, and we told them we actually suggested they modify their evacuation and emergency plan to include the hazardous substance that's released. So make your decision based on what is your emergency and then use the evacuation route accordingly. And educate employees on how to identify the tanks with potentially hazardous material and how to safely recycle them. So this was not the first incident apparently that happened in California. A similar incident occurred 2 months prior to this incident and which was not reported to the state health departments. Law enforcement investigation revealed that the tank actually came from the same location as it was in this incident. In order to educate the recycling facility and to prevent similar incidents in future, California Department of Public Health actually released a statewide alert on chlorine release to 1,200 recycling facilities. Both CDC and ATSDR contributed to this document, and this investigation was highlighted. The State Health Department also conducted a follow-up survey 6 months after this incident to assess the medical, mental health, and the legal services among individuals who were exposed. And also they still continue to monitor the needs of those who required long-term care. So now I will conclude here and wanted to thank all these different individuals at CDC, ATSTR, California Department of Public Health, American Samoa that actually helped with different investigation that I was able to participate in. So thank you. Questions? Yes.
On the last chemical spill, it seems one of the critical factors was the wind direction.
Yes.
Is that a constant? It's always coming out of northwest, or did your recommendations also include some type of visual and look at the flag or whatever before you run away?
Yes, and that was one of the suggestions. Actually, before we got there, that metal recycling facility already implemented that to actually consider those. But yes, the wind direction, it was basically huge fields around it, and then maybe a mile down the road there was some residential areas. So they never have wind direction coming from all over the place. So but that's something that definitely before we got there, they already added that to our. Yes, sir.
Going back to the first case, it's a little bit too far. Now, your operations in American Samoa are part of the SF6. It was contained within the support function?
It was contained within that, but CDC actually comes as a separate entity than FEMA, and also with it's all coordinated by HHS. But the different roles, the role that we played comes specifically from the Department of Health, but it was, yes. Yes. Yes.
So my question is this, you talked about your probabilistic basis sample
Mm-hmm.
household level. Is there not a problem with internally displaced people in American Samoa after the storm?
So actually there wasn't that much. There was some, but not that much. So it's not a big island. There's a lot of places for it. So majority of them actually moved uphill, if anybody who was living in the coastal areas. And one of the reasons our response rate was lower in the first time was because people were not home. They were just not in that. So we had that problem initially. But 3 weeks after, majority of them came back to their houses.
Question. Given that, and it's sort of too far, one has to adjust the probabilities for internally displaced people, right? So how do you take this methodology and apply it to Haiti?
Haiti is totally different area, totally different. So it all depends on your sampling frame. So how much we know. In American Samoa, one of the advantages, if we had to do this thing in the Republic of Samoa, we probably would have a very different results. American Samoa, we had information at the census tract level, so we were going with what we assumed that the census did in 2000. And that was our basic guidelines, that these are the areas where, and because it's not a big island, we didn't really expect a lot of movement, that people will be leaving. And I don't know how much familiar people are here with American Samoa, but nobody really owns the place in American Samoa. It's owned by the village. It's the head of the village that owns everything. So it's up to him to how long he wants you to stay there, because nobody's property is their own property. So we were going with whatever census did in 2000 and used that as a guideline, and that was our best guess at the time. So we just went with what we had. We didn't have time. We didn't even have the resources, and our timeline was so short that we had to use whatever was given to us.
Just a comment on chlorine. And some of you may know, in World War I, the Germans were the first to use gas warfare. Chlorine was the first gas they used. The first time they used it, they killed 6,000 Allied troops and opened miles-wide holes in the Allied line.
Yes.
This is serious stuff.
Yes. And one of the most, in the United States history, the most severe incident that happened was a train derailment that happened in South Carolina, 2004, where actually basically train moving chlorine derailed, and it actually spilled all over, and it was exposure within the community. And that was, in terms of public health, the largest chlorine-related disaster that I know of. And this was very small scale compared to all that. But yes, it's chlorine is for the chemical warfare is commonly used. Other questions?
How far was that recycling plant down?
Yeah, it was actually very pretty much outside of the city. It was not close to the city. It was mainly a lot of agricultural land around it. I think the first house that the residential area we came across was like 1.5 miles.
I understand that passport will be used for the Elk River
Mm-hmm.
So I was wondering if you could just very briefly talk about how that's going to be implemented.
Yes, I'm actually not officially involved in that process at all. Once I am involved, I would love to answer this question, but at this point, I have no knowledge about that. I knew that people were probably expecting that, but I asked them, but I'm not at this point involved. Okay.
Chlorine is also very common.
Yes.
And so, but it seems here chlorine gas.
Mm-hmm.
So what's the likelihood of chlorine-related problems, say, around the U.S., because it comes in different forms?
So one of the reasons ADSCR actually had the survey related to chlorine ready is because it's a very common problem, especially with the swimming pools and small exposure that happens. So the county health official deals with almost on the daily basis, especially at the beginning of the summer, because it's so widely used. So chlorine actually is their #1 chemical response that they do. Majority of them are at very small scale, and majority of them usually in the domestic settings. So yes, it is very common. Other questions, comments? Yes?
So they represent, could be one of you.
Yes.
So how did you go from here to EIS and this type of public health career?
They didn't like me here much, so they kicked me out. No. I basically did my MPH here. Dr. Rocker actually was my MPH advisor, and I did my PhD here. I've worked mainly with the Injury Control Research Center. I was not on the campus here because they have a separate building. It used to be on the Pineview Drive. I think they moved recently, which Dr. Coben used to be the director and still is. And my advisor just came from CDC, and he was faculty here. He didn't stay at WVU for long, Rob Bassett. And he actually introduced me to EIS. And so I attended an EIS conference. So those of the graduate students specifically want to know, there are around 6 to 7 travel fellowships to attend EIS conference for graduate students. So you can actually write an essay on why you're interested in, and there is a website at CDC. If you Google EIS CDC, it pops up and it gives you all the background that you need to know about the EIS program itself. And then there is the conference always happen in April, the last week of April. The classes or the new cohort that starts always is July 1st. The application for this year, or I would say 2015, are going to close on September 1st. So you have till September 1st to apply. And once the application closes for the applicants who wants to be EIS officers, then the application for the travel fellowship opens. You submit I think that's December 31st. And once you submit those, there is actually an internal review committee that reviews all those essays. And their main goal is to pick graduate students from different universities, especially from those where they don't have a lot of people applying from. And they want to increase. I was, if I'm not wrong, probably the first one from WVU to go. And then Penny Boffman, who was another PhD student, she was the second one to go. And so that they usually pick people based on. So you can apply for the travel fellowship to attend the EIS conference in Atlanta to stay there for a whole week, where you can attend the conference, get to know what people are doing, and also talk to they actually keep a separate session where they just want to talk to the graduate students, and they ask them about their interests, what they want to do, and if they want to apply. So that's how, right after I finished before I finished my PhD, I got into EIS. I graduated, moved to Atlanta. So if you're familiar with how the matching at the medical schools work, once you get your position, that's the same method they use for EIS as well. So you interview with 5 to 10 different positions that you think you really like. Then you rank them, they rank you, and where you actually match the best, that's your position that you get. My background was in injury epidemiology and environmental health. So when I was talking to different people, I had a best match with the National Center for Environmental Health. So I then specifically got placed with the disaster response group. And that's where I actually acquired the skills to disaster response and a lot of surveillance. So right after I finished my EIs, I stayed on with the National Center for Environmental Health. My work till last December was mainly focused on setting up surveillance system, data processing, a lot of data analysis. It was just sitting on a desk and crunching number all day. But in December, I called back to my outbreak investigation because they wanted me to come back because of the burden of the work they're doing and the expertise that I had. I think I was telling that to Dr. Coburn or probably Keith earlier. When I was doing the 2 years, that disaster response group's main focus is to do hurricane response because of the hurricane response that happens so often in the United States. From 2009 to 2011, when I was an EIS officer, there was not even a single hurricane that actually occurred in the United States. However, I had 7 earthquakes and tsunamis. So it just depends on the type of disaster that you deal with and the man-made disaster. So I ended up working with American Samoa, working with Haiti, working with Japan, with Chile. That's where different earthquakes happened during that time. And then obviously these other investigations are more domestic and localized. But we also do a lot of international work as well. That's an option if you want to be, and I think they have different selection criteria. There's majority of the physicians choose to be in the commission, but you don't have to. You can come in as what they call is a civil service or a Title 42, or you can be a commission corps officer, which is actually changing now because I think from 2015, if I'm not wrong, it's probably not going to be there. It's just going to be one type of. There's no commission corps after that.
Really?
Yeah. Thank you.